think one of the biggest mistakes in rehabilitation, I think it's a myth of rehabilitation, is that you do rehab to rehabilitate injury versus restoring optimum health in the person. And I think, listen, like no one likes doing clamshells. No one likes doing external rotations with a band. No one likes lying on their side and with a dumbbell. No one enjoys this exercise. No one likes it at all. So why not start from the premise of what is just healthy exercise? What are just the optimum health habits that we could cultivate in a patient, and then kind of trend in that direction. So instead of being like super focused and specific of like, okay, I'm going to rehabilitate this tendon, why not start from, well, how can we rehabilitate this tendon in the context of restoring optimum health in the person? So that's why, if you have a level 1 patient with a supraspinatus tendinopathy, why not start with pulls? Why not start with deadlifts, squats, lunges, and split stance row, right? You could do a goblet squat. Goblet squat is isometric loading and shoulder flexion. A little bit of co-contraction around internal and external rotators. You got to hold the bell and you got to hold it up. So external and internal rotators are co-contract and stabilize the shoulder in a shoulder flexion mechanism. It's usually or almost always pain-free, but you are loading the shoulder. Deadlift, what are you doing? You're loading the shoulder. If you put them into like a single arm front rack position, right? If they can hold that position and do a lunge, you're loading the shoulder. This exercise, if you hold this long enough, your rotator cuff is screaming at you, right? But it's a very safe position to load the rotator cuff. And then do split stance row. Train the legs, get a physiological response that is systemic in nature, which is, by the way, analgesic, right? General exercise is analgesic in nature. So why not take advantage of that endorphin and analgesic mechanism? And then when you're doing a pull, you are more anterior cuff than posterior cuff. So it's relative unloading of the posterior cuff, which is your irritable level 1 bit, but you can still load the shoulder as a whole. And by the way, a lot of people who have poor shoulder control are going to pitch the humeral head forward and anterior when they do a pulling pattern. So find specificity in controlling the axis of rotation around the glenohumeral joint while you're doing a pulling pattern. Then you're teaching optimum control, i.e. motor control of the shoulder that could preface them into training specificity of the tendon with reaching or external rotation mechanism, right? Why not do that? And then you're building health habits that also rehabilitate their shoulder. And patients will ask me, be like, so how long do I need to do these exercises for? I'm just like, well, how long do you want to stay healthy for? Like, like
Yeah.